Morning. We are students in PharmD University of Baghdad College of Pharmacy. Our presentation today is about cost-effectiveness analysis of pharmacological treatment for adult kidney transplant recipients in Colombia. My name is Elaf Kamil and I will start with introduction. Chronic kidney disease is a public health problem that affects 1 in 10 adults worldwide. In 2017, it was considered the third cause that generated the highest number of years of life lost because of premature death. Treatment of chronic kidney disease is focused on nephroprotection, management of hydrosaline and associated comorbidities, such as arterial hypertension, DM, and dyslipidemia and metabolic acidosis and hyperuricemia. In the final stage, kidney replacement therapy is necessary to compensate for metabolic damage in patients and ensuring longer survival. The kidney transplantation is the treatment of choice for people with advanced kidney disease, given the improvement that patients achieve in their clinical condition and quality of life after procedure. In Colombia, the prevalence of chronic kidney disease is 1.7 per 100 inhabitants in 2020 and is higher in women than in men. Kidney transplantation requires the use of lifelong immunosuppressive therapy to prevent rejection or loss of implanted organ. The management of immunosuppression in organ transplantation has no single pattern, and there is no consensus among the international scientific community. However, there is evident tendency to combine the drugs and establish management protocol in hospital center and transplant groups, according to the evidence of incidence of rejection and survival. The immunosuppressive treatment can be divided into the induction phase and maintenance phase. Induction phase therapy is administered at or around the time of transplantation and is usually consists of biological antibody. Maintenance phase therapy is usually initiated at the time of kidney transplant and continued for long term, and may include in the kidney transplant glucocorticoid, calcineurin inhibitor, and antimetabolite agent. The objective of this study is to combine the different pharmacological options in induction phase and maintenance phase in terms of their effectiveness and the cost, and to provide suggestions for decision making, and to evaluate cost-effective pharmacological treatment in adult kidney transplant recipients from perspective of Colombian health system. The methods. The cost-effectiveness of treating adult patients with kidney transplant in the induction phase and maintenance phase was estimated by combining various groups of immunosuppressive schemes from perspective of Colombian health system. The population considered in the analysis doesn't differentiate by kidney transplant type, sex, age, or other baseline or clinical characteristic. The evaluation was performed following the official Colombian recommendations for evaluation of health technologists, and statistical estimate were made with R software. For the induction phase, the decision tree was developed with a time horizon of 1 year.
Good morning, my name is Razan Adnan. I am a PharmD student at University of Baghdad College of Pharmacy. I will continue with methods which my colleague Elaf started it in the last slide of the presentation. The first two arms of the tree show that the patient may or not develop an acute rejection. In turn, the patient's graft may be successful or not. If the graft is lost, the patient being dialysis treatment or may die. And if the graft is successful, the patient lives or dies. And he may or not have an adverse event. A Markov model was built for the maintenance phase with monthly cycles and a time horizon of 5 years. 6 health states are considered, which are functional graft, acute rejection, additional comorbidities, acute rejections with acute comorbidities, graft loss, and death. Once a treatment is initiated with certain scheme, patient initiate the graft functioning stage. Subsequently, the patient may remain in that state or transient between the other states, represented by the ovals, as shown by the arrows in figure. In any of this stage, the patient may die. Both models have the following assumptions. First, the effect of the treatment is independent. Secondly, The probability of an adverse event occurring is independent of other adverse events and the probability of a transition between the states. The probability of terminating treatment because of adverse event is not considered. The probability of developing an adverse event in the maximum probability of the different acute adverse event, and the cost of each adverse event is weighed by its probability concerning the maximum. The temporal interaction between the different courses of action is not considered. And last, the patient entered dialysis in the state of graft loss. As we can see in that figure, we have two decision models. A, which is of the induction phase or decision tree. B, which is the maintenance phase or Markov model. As we discussed in the last slides of the presentation, we have two arms in the induction phase, with the both of them, one with acute rejection and the one with no acute rejection, and so on, as we discussed lately. Now we will talk about results for the group of the induction phase. The results indicate that rapid anti-thymocyte globulin combined with M is the dominant alternative. It reports lower cost and greater effectiveness. In the maintenance phase, it is observed that in group 1, which we used various of strategies, including cyclosporine, azathioprine, and corticosteroids. And the other one, which is cyclosporine, mycophenolate, mofetil, and corticosteroid, and other of these strategies are dominant because they are less costly and more effective than their comparator in each of the evidence group. It should be clarified that the differences in cost and effectiveness differ according to the set of tests analyzed. In contrast, in group 9, the cyclosporine, mycophenolate, mofetil, and corticosteroid alternative is more expensive but at the same time more effective concerning the cyclosporine, everolimus, corticosteroid. The ICER indicate that an additional life year has a cost of 6,479.4 US dollar, which compared with the cost effectiveness threshold show that the cyclosporine, mycophenolate, mofetil, and corticosteroid is a cost effectiveness analysis. In group 10, the cyclosporine, sirolimus, and corticosteroid alternative is more expensive and effective. However, the life year is small compared with the cost differences. Therefore, the ICER is 3,325.6 US dollar, and in comparison with the UCE, cyclosporine, sirolimus, and corticosteroid is not a cost-effective analysis. Finally, in group 11, the tacrolimus, sirolimus, corticosteroid alternative is more expensive and more effective than its comparator, the tacrolimus, mycophenolate, mofetil, corticosteroid. However, the ICER give a value being higher than cost-effective threshold, indicate that is it not an cost-effective analysis.
Good morning, my name is Ruaa Sabah. I'm PharmD student at the University of Baghdad. Continuation. Conclusion. It is possible to conclude that the result in the base case for each group of evidence, inductions and maintenance, are consistent across different sensitivity analysis and the threshold. Even for above 3 GDP PC for the Colombian context, it is important to recognize that the result of this study make a significant contribution to the treatment of patients with a kidney transplant in the Colombian context because, to the best of our knowledge, it is the first health economic evaluation that considers two alternatives. For recommendations in future research and subject to the available evidence, it is expected that a study with more alternatives can be performed, and it can compare all alternatives in the same group. For our critical, in order to undertake a similar economic study in Iraq, we must take into account certain aspects that may be encountered in Iraq. Number one, conducting this study in Iraq would be challenging due to the need for patient long-term follow-up. Number two, Iraqi hospitals rarely use electronic registrations method, which may result in statistical error. Number three, Kimadia's budget is restricted to a little more than $1 billion. Number four, there is a shortage of resource and a lack of specialized knowledge in the field of health economics in Iraq. Number five, the study in Colombia involved a large number of patient groups who underwent the treatment suggested in these investigations. Implementing this in Iraq necessitated a substantial volume of data, financial capital, and sustained surveillance. Finally, number six, we can't confirm the patient's adherence to treatment, which lead to rejections of the transplanted kidney or other life-threatening issues, hence causing inaccuracies and error in the obtained data. Thank you all for listening.